Good afternoon. It is a great pleasure for me to present this paper from the Garfield VTE study on behalf of the steering committee members, the national coordinators, and the investigators that have contributed to this study. Garfield VTE is a prospective observational study that enrolled 2 consecutive cohorts, each including 5,000 patients, for a total of more than 10,000 patients, with the aim to describe baseline characteristics, management strategies during the acute phase as well during the extended phase of the disease, and also cost associated with venous thromboembolism with a 3-year follow-up. The study was truly global. As you can see from this slide, we reached all continents and involved 28 countries for more than 400 centers. In each country, since we aim to reflect as much as possible the actual management of venous thromboembolism, in each country, we requested a list of centers who manage venous thrombosis, and we randomly selected centers. In this slide, you can see the breakdown of patients managed by different specialists in this study. So as you can see, majority of patients were managed by vascular medicine specialists, by internal medicine specialists, but please mind that here we also include hematology and intensive care, by cardiologists, but here we have a smaller proportion of patients, primary care doctors, and emergency medicine doctors. The aim of my presentation is to describe the baseline characteristics of those patients, all patients enrolled in Garfield VTE. Enrollment started in May 2014 and ended in January 2017. We assessed for eligibility across all centers a total of 11,842 patients. This is an observational study, so we had very few exclusion criteria, but few patients were excluded, 964, mainly because they either declined to participate or because they did not meet some pre-specified criteria, mainly participation in an interventional study or unavailability for the long-term follow-up. Also, 61 patients died before consent. Of the 10,878 patients who were enrolled, a few more were excluded because we could not find an objective confirmation of the diagnosis of venous thromboembolism, thus leaving a total of 10,677 patients. If we look at the breakdown between patients with DVT only and patients with pulmonary embolism plus or minus DVT, this is very much in keeping with what is known in the literature, with about 2/3 of patients with DVT only and about 2/3 of patients with pulmonary embolism. If we look at the proximity of pulmonary embolism, we heard in previous talks about this topic, we see that nearly 1/3 of patients had their emboli involving the main arteries, and on the other end of the spectrum, we see that about 10% of patients had isolated subsegmental pulmonary embolism. Baseline characteristics were really in keeping with what is known in the literature. The 2 genders were equally distributed, as you can see here. The median age was 60 years, and I show here, very important to observe, we have 9% of patients with active cancer, 6.2% of patients with history of cancer. In addition to that, we had 37.5% of patients in whom venous thrombosis was judged to be provoked by transient risk factors using the recently proposed classification by the scientific subcommittees of the International Society on Thrombosis and Hemostasis. So about 45 to 50% of our patients had a so-called unprovoked venous thromboembolism. Some of the most frequent risk factors are listed here, and of course, some of these risk factors may have been coexistent in patients. Looking at contemporary diagnostic approaches, I think it's no surprise to look on the left-hand side of the slide. 95% of patients had DVT diagnosed by means of compression ultrasonography. Fewer proportion had the diagnosis with the use of CT scan or even contrast venography in 1.5% of patients. On the other hand, only in 25.7% of patients, the investigators declared that D-dimer was used in the diagnostic assessment of these patients with objectively confirmed deep vein thrombosis, and even fewer had pre-test probability score use according to what was reported by the investigators. For pulmonary embolism, again, no surprise, 92% of patients had diagnosis by means of CT scan, 10% by means of ventilation perfusion scan. In some countries, this may be only perfusion scan performed. Once again, the use of biomarkers, which also included D-dimer, so not only troponin and BNP, was reported in only 16% of patients, and the use of echocardiography in 14% at the time of diagnosis of this disease. Moving on to therapeutic strategies, 86% of patients received treatment using anticoagulant agents only. There were also 9% of patients who did not receive any therapeutic strategy, only compression stockings at best, whereas a total of about 5% of patients received either thrombolytic therapy, 3.1%, or surgical mechanical treatment. If we only look at patients who received anticoagulant treatment, this is the picture on how we are now treating venous thromboembolism. You can see here that 14% of patients were treated with parenteral anticoagulants only. 30% of patients received what we have called for many years standard of treatment, that is parenteral anticoagulants followed by vitamin K antagonists. And here you have to add 4.6% of patients for whom apparently only vitamin K antagonists were prescribed. This leaves the remaining 50% of patients with venous thromboembolism who are currently receiving direct oral anticoagulants, either 50% of them following a leading period of parenteral treatment or as a standalone treatment. If we break down by deep vein thrombosis and pulmonary embolism plus or minus deep vein thrombosis, there is not really a difference in the use of low molecular weight heparin or low molecular weight heparin or unfractionated heparin or fondaparinux and vitamin K antagonists, very similar. So the overall use of the direct oral anticoagulants is comparable between patients with DVT and PE. The difference is the use of lead-in parenteral treatment, which is certainly more commonly used in patients with pulmonary embolism as expected. So the the clinical conditions which were associated with the lower use of direct oral anticoagulants included active cancer, but about 25% of patients did receive treatment with direct oral anticoagulants. The large majority received treatment with parenteral anticoagulants, low molecular weight heparin in particular, according to the guidelines. The use of direct oral anticoagulants was higher in patients with history of cancer, still below what we observed in the general population. And with some surprise, I was interested in this observation, the use of standard of treatment was still prevalent in patients with recent bleeding or anemia, so doctors prefer to use standard of treatment in these patients. So in conclusion, this first picture from this large global international study, Garfield VTE, shows that treatment patterns are certainly changing over time. A few years ago, of course, we did not have the direct oral anticoagulants. Now, the direct oral anticoagulants are used in approximately half of the patients overall, with some differences in different regions of the world. And a similar proportion of patients with DVT-MP. The difference between DVT-MP patients is represented by the use of parenteral drugs before introducing the direct oral anticoagulants. And before I close, I wish to thank all physicians, nurses, and patients. This has been and continues to be a great effort. Patients are followed for 3 years, so the study is currently, of course, ongoing. I would like also to thank Thrombosis Research Institute in London that made everything possible. Thank you very much.